ആമേൻ. സ്വർഗസ്ഥ പിതാവാം ദൈവമേ, താങ്ക് യു ഫോർ ദിസ് ബ്രാൻഡ് ന്യൂ ഡേ. ഈ ദിവസത്തിനായി നന്ദി. ഈ ഭൂമിയിൽ ഞങ്ങൾ ഇന്ന് ജീവിക്കുമ്പോൾ ഞങ്ങളുടെ ജീവിതം മറ്റുള്ളവർക്കൊരു അനുഗ്രഹമായി തീരുവാൻ ആണ് ഞങ്ങൾ ആഗ്രഹിക്കുന്നത്. അതിന് പ്രകാരം ഈ വ്യാഴാഴ്ചയും ഞങ്ങൾക്കിവിടെ ഇതുപോലെ കൂടുവാൻ ദൈവം ഞങ്ങളെ ഒരുക്കിയതോർത്ത് നന്ദിയും സ്തോത്രം അർപ്പിക്കുന്നു. ഇന്ന് ഡോക്ടർ പ്രതാപ് ചന്ദ്രനായി നന്ദി. വളരെ ദൂരെ നിന്ന് ഞങ്ങളുടെ ഇടയിലേക്ക് വന്ന് പുതിയ കാര്യങ്ങൾ ഞങ്ങളെ പഠിപ്പിക്കുവാൻ ഇന്ന് അങ്ങ് നിയോഗിച്ചിരിക്കുന്നതോർത്ത് നന്ദിയും സ്തോത്രം അർപ്പിക്കുന്നു. ഇനിയും ഞങ്ങൾ കേൾക്കുവാൻ പോകുന്ന കാര്യങ്ങൾ ഞങ്ങൾക്കും ഞങ്ങളുടെ മറ്റ് സഹോദരങ്ങൾക്കും ഈ ഇൻസ്റ്റിറ്റ്യൂഷനും ഒരു വലിയ അനുഗ്രഹമാക്കി തീർക്കണമെന്ന് പ്രാർത്ഥിക്കുന്നു. വന്നിരിക്കുന്നവരെയും ഇനിയും വരുവാൻ ആഗ്രഹിക്കുന്ന ഓരോരുത്തരെയും കൂട്ടിക്കൊണ്ട് വരണമേ. ഒരുമിച്ച് ഞങ്ങളെ അനുഗ്രഹിച്ചാട്ടെ. പ്രാർത്ഥന കേട്ടതിനായി സ്തോത്രം. യേശു ക്രിസ്തുവിൻ്റെ വലിയ നാമത്തിൽ തന്നെ ആമേൻ. Please be seated.
Thank you, Achan. Today, our quest is focusing on surveillance. Surveillance is to see what our problems are, how big they are, and what solutions can be intended for that particular problem. And it doesn't stop with that, whether the solutions, how the interventions, how effective they are. So today we have with us Dr. Prathapa Chandran C, State Surveillance Medical Officer working with the World Health Organization, Kerala Division. So he is an expert in surveillance and he is expecting our cooperation to strengthen the surveillance in Kerala so as to combat the vaccine preventable diseases. Welcoming, sir.
ബഹുമാനപ്പെട്ട പ്രിൻസിപ്പൽ മാഡം and all the senior professors and all who have gathered here. Thank you. More than an academic session, this was a request session rather. We want a big support from you to strengthen the surveillance. This being a medical college, support from a medical college is very important because of a couple of things. One, the number of patients we have. Two, the JRs, SRs, postgraduates, interns who complete their academics from this hospital, they get scattered across the state or across the country or even beyond that. And whatever support or whatever request we have today, if they keep in their mind and support us in the program in future, this meeting will be an investment for us for the future. So that's what we have in mind. So this is a topic, VPD surveillance. അപ്പോൾ VPD surveillance പറയുമ്പോഴത്തേക്ക് it's vaccine preventable disease surveillance. There are almost 13 vaccines being given or 13 diseases against which vaccines are being given by the Government of India program as on today. And from the IAP sector and from the private sector, another maybe 7 or 8 additional vaccines. But in surveillance, we are focusing on some of the diseases. But another major difference for a clinician, it's that one patient sitting across the table. ആ ഒരൊറ്റ പേഷ്യൻ്റാണ് ഫോക്കസ് എന്ന് പറയുന്നത്. Treat that patient. When that patient becomes well, cured, he is happy, we are happy, everything is settled. But from the public health perspective, that's only a starting point. You come across one disease, you report it, and it's a starting point. Many things happen behind the scenes. Like, for example, you have a case of suspected diphtheria. You manage the case wonderfully, you save the patient goes home happy. But the second you report that you have a suspected diphtheria, the first thing we do, we inform that ward or village where that patient or that person belongs to. Second step, our health worker, they will make a contact list. Close contacts, casual contacts, and high-risk contacts. 3, they do a house-to-house search in that area for additional cases. At the same time, they verify the vaccination card of all the children up to 5 years of age in that area, or up to 5 years or even 7 years in that area. If any child is missed out on any of the doses of vaccine, that child will be immunized. Then all these close contacts, they will be put under surveillance for maybe 2 weeks for any symptoms. If they develop any symptoms, we collect sample from that patient, from that person. We give antibiotics to all those close contacts to prevent them getting infected. We immunize them if they have not received a diphtheria containing vaccine in the last 5 years. And from the patient, from the first or the index case, we collect the sample and send it across to an accredited lab for both culture, ELECTRS for toxigenicity, and a PCR. And this will be notified to the district, to the state, as well as to the national level. In addition, all the health workers in that area will be sensitized if it's a positive case that we have a confirmed diphtheria in that area, so that the next time somebody comes with a sore throat, at least the clinician will, you know how the OP situation in a PHC, huge OP, maybe 150 to 200 OP per day. So sore throat, even without looking at the throat, they are forced to write a medicine for that patient. So once they know that they have diphtheria in that area, at least they will ask that patient to open the mouth, put a torch, and see for any membrane or patch or some signs of diphtheria or something else. That's one thing. Second, we sensitize the public in that area, especially the elected representatives, our own field staff like ASHA, Anganwadi, all those workers, so that if there's a case of sore throat or fever in that area, that will be reported immediately rather than going to a local medical shop and getting the antibiotics. So these many activities will happen when you report a case of suspected diphtheria. For you, it's one case of diphtheria, you manage that case, you send the case home, happy, cured. But for us, it's a starting point, and we do this many activities. But to initiate this activity, the request or the support is to report that case. So that's all about today's presentation, to report the cases which comes under this surveillance. Okay, this is what I was trying to tell you. These are the activities that will happen behind the screens when you report any of these VPD cases. Okay, these are the conditions which are under scanner at present, under this VPD surveillance from Government of India and from the state government. For polio, we have AFP or acute flaccid paralysis surveillance. That's for polio. As all of you know, the last case of polio from India was in 2011. After that, no cases reported in spite of having a good surveillance. 2014, India and all the 11 countries in the Southeast Asia region of WHO were declared as polio-free. But unfortunately, even today, we have polio cases happening in the world. Last year, we had 12 cases of polio reported from 2 countries, 6 from Afghanistan, 6 from Pakistan. And the previous 2 years, we had cases from African countries of Malawi and Mozambique. Genetic sequencing showed that these outbreaks in Mozambique and Malawi, which were polio-free for more than 20-25 years, it happened from importation from these 2 countries. So that's the risk. When you have a polio virus, anytime it can cross, it doesn't need a visa to cross borders. It can come anytime. So to pick up those cases, we need a good surveillance and a strong immunization. That is one thing. And second, these 12 cases are from paralytic children from whom we collect the sample and send it across to the lab. In addition to the cases, we take samples from the environment. We take samples from the sewage, from the drainage. That's happening in India. That's happening in Kerala. From Trivandrum and in Kozhikode, we have started doing that since last year. Every week, we collect sample and send it across to accredited lab. They process it for wild polio virus, vaccine virus, and VDPVs. And in that sample, from Afghanistan, we got around 60 plus wild polio virus and more than 145 wild polio virus from Pakistan. That shows wild polio virus circulation is still happening in the world, that too in our neighboring countries. So that's a threat for us. So we need to continue with the polio surveillance or AFP surveillance, even though we are certified as polio free, though we don't have a case since 2011 Jan. That is polio or AFP surveillance. Second one, this is another ambitious program from Government of India, eliminate measles and rubella. From the success of polio eradication, the next two diseases which are selected is measles and rubella. And for that, we have a surveillance program called fever rash surveillance. Then the other three conditions are diphtheria, pertussis, and neonatal tetanus. Okay. All the youngsters sitting here, you are maybe lucky or you are unlucky, whichever way you look at it. You are lucky, you haven't seen a case of polio in its acute phase. You are unlucky, as a medical student or a medical personnel, you haven't seen how to manage an acute case of polio. While we were students, we were house surgeons, we were postgraduates, every day, especially in a monsoon season, we used to have at least one case of polio getting reported from our OP or from our casualty. We had a polio isolation ward. And it's a sad thing to tell the mother or the caretaker that this child is going to be, what's the politically correct word, differently abled, or this child is going to be differently abled, or whatever that politically correct means, for life. That's a very sad thing. But you haven't seen that. Thanks to immunization, thanks to surveillance, but still the threat is very much there. So this is what I was trying to tell you. Last year we had around 12 cases, and year before we had 30 cases, and 8 cases from Mozambique. That outbreak happened from virus going from Pakistan and Afghanistan. So this is the request. This is the request. If you come across a child under 15 years of age with any paralysis, please do report immediately. By definition, this is a definition for acute flaccid paralysis. A child under 15 years of age with a flaccid paralysis any part of the body. But when you are reporting any paralysis in a child under 15 years, please do report. Irrespective of your clinical diagnosis, irrespective of the associated symptoms or signs, irrespective of the immunization status, please do report. The list can be huge. It can be GBS, ADM, transverse myelitis, traumatic neuritis, hemiplegias, monoparesis, paraparesis, bulbar palsies, ocular palsies. The list can be huge. But rather than enlisting all those conditions, only two exceptions. One, if the paralysis is more than 6 months, from the onset is more than 6 months, it is not acute anymore, please don't report. Two, when you examine the case, there is an element of spasticity or rigidity. It is not flaccid anymore, please don't report. Every other case, please do report. A child is limping. We don't know why the child is limping. Maybe it's myositis, maybe it's neuritis, maybe your diagnosis is synovitis. But when you do a scan, when you do an X-ray, no fluid, please do report. Please do report. Transient paralysis. Child gets a fits. Child is not moving one part of the body or limb or half of the body. Your diagnosis, maybe it's a Tort's palsy or a post-ictal palsy, but for us, it's an acute flaccid paralysis. Please do report. A child gets diarrhea, vomiting, and child becomes a pit frog, totally floppy. You give Ringalactid, you give ORS, child becomes okay. For you, it's a dyslexemic transient paralysis, but for us, it's an acute flaccid paralysis. Please do report. Somebody has given a gluteal injection to a child. Child starts limping. Maybe it's a chemical myositis, maybe it's a myositis, it can even be a traumatic neuritis. But for us, it's an acute flaccid paralysis, please do report. So irrespective of the diagnosis, last week we had a case reported from the pediatrics department, one ADEM child, it was reported, now the child has been referred to SAT and child is in SAT hospital. Irrespective of the diagnosis, please do report. Even if you are referring to a higher center, still report. Because surveillance is good when the case gets reported on the first contact point where the child goes to. Then it's a good surveillance. Many times what happens, the first point it will not report, second they will not report. When it goes to a tertiary hospital, it gets reported. Okay, that's fine, but that shows a surveillance failure. So request, if any child under 15, any paralysis, irrespective of that, don't even wait for a diagnosis, please do report. Later on, if it happens to be something else, we can always take it out from the list. Child is limping, maybe it's a thorn prick. Okay, later on, if you prove that it's a thorn prick, we can always take it out. But please do report. Why it's important? Because we have to collect samples within a time period, within a window period. If you report it late, the sample collection gets delayed. Once the sample collection delayed, the diagnosis gets delayed. When the diagnosis gets delayed, the entire process becomes complicated. So please do report. Then if someone is above 15 years, only if you're clinically suspecting polio, then only report. Because 99% of polio happens under 15 years of age. So, but above 15, if you clinically suspect polio, do report, but below 15, irrespective of the diagnosis. Okay. So what we do when you report a case, the first thing will be to collect a sample. This is the sample we need. From every case of acute flaccid paralysis you report, we collect 2 stool samples. Ideally, within 14 days of onset of paralysis, but we collect it up to 60 days. But any sample collected beyond 14 days is taken as an inadequate sample by the lab. Meaning, even if it's a case of polio, you may not isolate the virus, because after 14 days, virus excretion becomes less and less as each day goes by. So ideally within 14 days, but up to 60 days we collect sample. And we need 2 samples. Each sample minimum 8 grams. We don't need a weighing scale for that. An adult thumb size or a standard container, at least half or just above that standard container, we need to collect the sample. 2 samples, interval of 24 hours, minimum interval of 24 hours apart. Why 24 hours apart? Because viral shedding, even if there's a virus, the viral shedding is not continuous. So to get a better sampling, we need 2 samples. And both the samples should go to an accredited lab. There is only one accredited lab for the entire state of Kerala, and that is NIV Bangalore. All the sample collected from all the AFP cases, it's sent to NIV Bangalore. Once it reaches Bangalore, they process it for wild polio virus, vaccine-derived polio virus or VDPV, and non-polio enterovirus. They process for all these 4 things and they give the report to us. And that report will be shared with the reporting physician or reporting hospital and to the district medical officer, not to the patient directly. So this is one thing. And this is how we classify the case. Once you send a sample, and if it's a wild polio virus positive, irrespective of any other thing, it's a confirmed case of polio. If it is negative, that negative will hold a value only if you could collect both the samples within 14 days and satisfying all the criteria. Then we discard it as non-polio acute flaccid paralysis. But if the samples are collected late, or if it's an inadequate sample, or we could not collect a sample, then we do a 60-day follow-up. After 60 days from onset, we follow up the child for any residual weakness. If any residual weakness, then it becomes an issue. Then we cannot classify it. We have to send the entire sample, entire documents of the child, the treatment documents, nerve conduction studies, EMG studies, then epidemiology of that area, immunization status in that area, the last case of polio in that area, other vaccine preventable disease, and all these documents will go to an expert committee. They will decide whether we can discard it as non-polio or this could have been polio. Then we call it as a compatible polio case. That is worse than having a wild polio because it shows surveillance failure also. Okay, this is how we classify the cases. And these are the things we do. The case management, it's up to the clinician, they will manage the case. We get the case reported, within 48 hours it will be investigated, and there's a standard case investigation that will be filled. The samples will be collected and sent to the lab. Then all the public health response. We do an active case search in that village or ward, wherever the child is, for additional case of paralysis in that area. And at the same time, in that ward or village, surrounding that particular index case household, around 500 children will be given additional dose of oral polio vaccine as a preventive measure. And we verify the immunization card of all the children, and if any child is missing out or left out for any of the dose of any of the vaccines, that child will be vaccinated. So these are the public health response activities we do. So the request, forget about all the slides. So only one request. If you come across any child under 15 with any paralysis, including facial palsy, including ocular palsy, including ptosis, including Todd's palsy, including dysautonomic paralysis, don't wait for a dense paralysis, only limb paralysis, no, anything, even a phantom hernia, please do report. So that's the first thing. So first topic is over. Next is measles rubella elimination. That's a major program now. In fact, the time frame was December 23rd, which it's already over and we couldn't. Definitely we will do it. The main difference in measles rubella elimination and polio eradication is, for polio eradication, a district, state or a country cannot get certified as eradicated. That entire region, every country in that region has to satisfy all the criteria for eradication before getting certified. But for measles rubella elimination, the unit is a district. So each district, if it fulfills all the criteria, that district can get certified as eliminated measles or rubella. And these two are two separate certifications: measles elimination certification, rubella elimination. So with the support of each one of you, maybe Pathanamthitta can be the first district in the entire country to maybe eliminating one of these diseases in 2024 itself. But to eliminate, is it easy? It's very easy. Java pole eluppamanu. We need to do only a couple of things. One, immunize every child under 5 with 2 doses of measles rubella containing vaccine. It can be MR vaccine, MMR vaccine, MMRV, whatever. 2 doses of MR containing vaccine. That's the thing. Second, have a fever rash surveillance, so that we can pick up which all areas are, we can focus on areas where we have measles or rubella outbreaks. After we started this fever rash surveillance, you might have read in the paper, last year we had huge outbreaks identified in Malappuram, Palakkad, Kannur, Kasaragod, Ernakulam and even Trivandrum. We could pick up. This was happening in the previous years also, but we missed out. But once the surveillance becomes strong, we pick up cases. We thought rubella is only in your textbook. But last year, we had 70 cases of lab-confirmed rubella identified, in spite of having a very low number of fever rash cases reported. Many of you might have seen at least one fever rash case last week in your OPD. Not many of you, all of you might have seen at least one case of fever rash, because we have so many fever rash cases. But the reporting of fever rash cases is minimal, even absent. We are getting only very few cases reported. From those cases, we could get that many, even rubella could be picked up. So once we know that which area has maximum number of cases, we can initiate public health response, strengthen the immunization, strengthen the surveillance, strengthen the vitamin A prophylaxis in those areas, so that the complications are negated and more cases are prevented, outbreaks are prevented. So these are things we need to. So one is immunization, that anyway we are doing it. Second, fever rash surveillance for MR elimination. This is where we need your support. So these are the things we need to do for elimination. 95%. Ideally it should be 100%. At least 95% of children under 5 years should get 2 doses of MRCV or measles rubella containing vaccine. Second, this is a major concern for us, dropout rate. 100 children will come for BCG. 98 will come for the first dose of Penta. 97 for second dose of Penta. 95 for third dose of Penta. 90 for MR. 80 for the booster dose. So as each month goes by, the number of children coming for vaccine, maybe reasons can be varied, but this dropout rate is a concern. And so the next indicator will be the dropout from measles 1 or MR1 vaccine to MR2. MR1 is given at completion of 9 months of age, and MR2 is given at completion of 16 months of age. It should be 0. Every child who gets a first dose should get a second dose when the child crosses 16 months of age. So that's the second one. Third, fever rash surveillance, which we will come into. Third, incidence. Incidence is for every 1 million population. It should be 0. I will show you what's the incidence now. It's more than 80. More than 80 is the incidence at present for Kerala. Each district varies. Then every district, every block, every PH area should report fever rash cases. No area should remain silent. A silent area means we don't know what's happening there. Even if a measles outbreak happens, we won't know. Even if a polio happens, we won't know. Even if a diphtheria death happens, we won't know. Unless and until it becomes an outbreak or Asianet or Manara News comes with a camera, we won't know about it. So every district, every block, every PSC should at least one case of fever rash. And the last, if an outbreak happens, we should be prepared to tackle that outbreak. There are many things we need to do when there is an outbreak. That luckily we are prepared. We are prepared for the outbreak. Every district is prepared for an outbreak with a plan. So these are the things we need to do. I'll be focusing only on fever rash surveillance, where we need each one of your support. This is what we need. If you come across a fever with a rash, maculopapular rash, please do report. Here, one point, no age restriction, any age. Fever with maculopapular rash, please do report immediately, irrespective of, again, your diagnosis, irrespective of the associated symptom signs, whether complex spot is not there or not, whether the conjunctival congestion with purulent discharge or not, even irrespective of any of the associated signs or symptoms, please do report. It can be fever followed by rash, rash followed by fever, fever rash coming, whichever combination. Fever, maculopapular rash, please do report. Please do report, irrespective of the age. Irrespective of the age, irrespective of the immunization status. Because we have seen confirmed measles and rubella in children who have received 1 or 2 doses of measles vaccine even. Reasons may be many, but we have seen it, so please do report. Earlier, 2 years back, it was measles rubella surveillance, when we used to say that fever, rash with one of the 3 C's, like cough, conjunctivitis or coryza, but now it's not there. So no age restriction, no associated symptom sign, fever, maculopapular rash. Again, what we do, details should be filled up in this particular format, and we collect samples, just like in AFP. In AFP, we collect 2 stool samples, 24 hours apart, within 14 days. Here, we need 2 sets of sample. One is a serum sample. That is for IgM, measles and rubella. This can be collected up to 28 days from the onset of rash, not from fever, from the onset of rash. Up to 28 days we can collect. We do IgM, measles and rubella from this sample. And second is a virology sample. It can be a swab. It can be a nasopharyngeal swab or a throat swab, or it can be a urine sample. The yield from the urine sample is slightly less than the swab, but for the swab we need a transport medium. There are only 2 accredited labs for sending these samples for Kerala. One is NIV Alappuzha, and second is State Public Health Lab at Trivandrum. We need to send a sample to either of these labs. Virology sample can be collected up to 7 days, because after that the viral shedding or viral yield will be almost nil. So up to 7 days. So if a patient is reported within 7 days, we collect both the samples. If the child is reported, if the person is reported within 28 days, we collect only serum sample. And if it is beyond 28 days, still it can be reported, but we won't collect any sample. But any case reported without sample, by algorithm, it becomes a clinical measles, unless you have other confirmed diagnosis, lab confirmed diagnosis. Okay, this is how it is. And these are the public health response activities we do whenever you report a case. 1, the case will be investigated within 48 hours. Samples will be collected. It will be sent to an accredited lab. If the child is not hospitalized, we isolate the child, isolate that person, try to isolate that person for 4 to 7 days. Additional vitamin A will be given to all those cases. 2 doses of vitamin A 24 hours apart, depending on the age or weight of the case. It will be given. Then, just like the other cases, we do an active case search in that community, in the village or in the ward. Every house will be visited for fever rash case. The last 3 months and ongoing cases for the next 28 days. We do that surveillance. All the vaccination card will be checked for left out or drop out children, and if a left out drop out child, that child will be vaccinated, and every case will be followed up after 30 days, because most of the complications of measles happens after maybe 2 weeks, or you know better, maybe after 2 weeks. Otitis media, maybe meningoencephalitis, maybe diarrhea, maybe pneumonia, whatever. Even malnutrition, everything happens usually after 2 weeks of age. So we do a 30-day follow-up. And if it's a lady in the fertile age group, one of the questions asked will be about pregnancy. And if that lady is pregnant during that period, and if the lab result comes as rubella positive, that lady will be followed up throughout pregnancy, and once she delivers, that baby will be screened for congenital rubella syndrome. So these many activities will happen whenever you report a case of fever rash case. പണ്ട് ചന്ദ്രനിൽ ഇറങ്ങിയപ്പം നീൽ ആംസ്ട്രോങ് പറഞ്ഞൊരു സ്റ്റേറ്റ്മെൻ്റ് ഉണ്ട്. എന്താണ് പുള്ളി ഏതാണ്ടോ പറഞ്ഞു അവിടെ നിന്നുണ്ട്, ഇറ്റ്സ് എ സ്മോൾ സ്റ്റെപ്പ് ഫോർ മാൻ ആൻഡ് ഇറ്റ്സ് എ ഹ്യൂജ് ലീപ്പ് ഫോർ എ മാൻ കൈൻഡ് എന്നൊക്കെ അത്രയൊന്നും പറയുന്നില്ലെങ്കിലും, ഫോർ യു ഇറ്റ്സ് റിപ്പോർട്ടിങ് എ സിംഗിൾ കേസ് ഓഫ് ഫീവർ ആൻഡ് റാഷ്, ബട്ട് ഫോർ ഇറ്റ്സ് എ ഹ്യൂജ് സെറ്റ് ഓഫ് ആക്ടിവിറ്റീസ് ടു പ്രിവെൻറ്റ് ആൻ ഔട്ട് ബ്രേക്ക്, to prevent complication and to eliminate a major disease. So today, maybe you feel that too many slides and too many unnecessary things to be stored in your memory chip. Take only this one request. If you have fever rash, please do report, because that's a major thing that's coming up. Elimination of 2 major diseases, measles and rubella. These are the number of cases that happened. See, the first thing, that 114/1854, that one is the number of fever rash cases reported over the years. When we started this program in 2021, only 114 cases are reported from across the state. From 14 districts, we got only 100 cases of fever rash. Think of it. But luckily, by last year we had around 5,600 odd cases, but still it's a very small number when compared to the actual number of fever rash cases. I am not saying measles, I am not saying rubella. Fever maculopapular rash case, it's a very small number. Actually, we are not getting cases reported. I don't know whether you would like it or not. The number of fever rash cases reported from this medical college itself is very few. See, it's a medical college. You have such a huge catchment area. You have such a huge number of patients coming every day to medicine, to pediatrics, to dermatology, to infectious disease, to gynec. And at least some of them will be having fever rash. And some of the rashes will be maculopapular. But it's not getting reported. Because for a clinician, I won't blame anyone. For a clinician, it's a patient treat. It's a fever rash. Maybe it's an allergic rash. Maybe it's a viral-like symptom. Give something, 3 days, 2 days, they are fine. All are happy. But for surveillance, we are not happy. We need every case to be reported. We are not looking for measles, rubella. We are looking for all fever rash, just like diarrhea. It's a syndromic thing. Diarrhea, we are not worried whether it's a bacterial, viral, or fungal, or even a chakparam diarrhea. We are not worried. For us, it's a diarrhea, ADD. It's a syndrome. Like that, for us, it's a fever rash. So last year, we got 5,600, out of which around 5,000 we could collect sample, and we got around 2,600 lab confirmed cases of measles. Almost 50% measles positive. We think, or we always say, Kerala is great, our immunization is one of the best. But see the data. This is from the small 5,600. We got this many, and we got 70 cases of lab confirmed rubella. Then we have others also, epidemiologically linked ones. We couldn't collect the sample, but there's a definite history of contact with a lab confirmed case. We do have such cases also. Okay, so these are the number. Already in Jan itself, we got this many cases already reported. 165 cases reported already, and 152 samples collected. Already 52 confirmed measles cases. In Jan 2014 alone, 2024 alone, and 6 rubella cases. So my request to every department, please do report. Please do report. Okay. And when we have an outbreak, that's a huge activity which I am not going to discuss today. We will be doing these many activities whenever we have an outbreak in any area. And again, these are the activities we do. And in DPT surveillance, these are only just a request. If you suspect a diphtheria, forget about the diagnosis and everything. If you suspect a diphtheria, please do report. And what we collect is a sample from that membrane or patch wherever you have. It's a nasopharyngeal, take nasopharyngeal. If it's a throat, take a throat swab. And we need 2 swabs in a transport medium called AMIS transport medium. And the sample goes to State Public Health Lab, Trivandrum. They do culture, they do toxigenicity elect test, and they do PCR. Even if you are sending a sample to your lab, still send one set of sample to this particular lab so that that report is accepted, because only from accredited lab the reports are accepted. Okay. And this is about pertussis. Whenever you are suspecting pertussis or pertussoid cough, we need 2 sets of sample again. One is a serum sample which we can collect up to 12 weeks. 12 weeks, because we are doing IgG for pertussis. So we can collect sample up to 12 weeks. And we need a nasopharyngeal swab. Here the point is, please don't send a throat swab for pertussis. You won't get anything. We need a nasopharyngeal swab. And the transport medium is RL or Reagan-Low transport medium. That's what we use. There are many transport mediums, but in Kerala we use RL transport medium. And again the sample goes to State Public Health Lab. They do culture, they do PCR, they do IgG. Okay, neonatal tetanus is a clinical diagnosis. Luckily we don't have any neonatal for a long time, but still if you have, but no sample collection. So these are the things we need. Okay, this we already discussed what all things we do, and this is what we do. Whenever case management is one part, that's to the clinician, but we do a prophylactic antibiotic for all pertussis cases and all diphtheria cases. We do prophylactic antibiotic and we give antibiotic, diphtheria containing vaccine for all the close contacts. And this is a request. This is a request. If you come across any AFP, fever rash, diphtheria, pertussis, or suspected neonatal tetanus, please do report immediately. Please do report immediately. Please don't wait for a confirmation. Please don't wait for an approval from your HOD or from your professor, because we need that time frame to collect the samples. 7 days for a swab in a measles rubella, 14 days for an adequate stool sample, 28 days for us. So we need that window period. We have a very small window period. Please do report. When you report, these are the minimum data we need: name, age, sex of the patient, and a contact number. Address and a contact number. Even if the address is incomplete, if we give a contact number, we can track the child or the patient wherever they go. And date of onset, because the lab report interpretation depends on the onset. Onset of paralysis in an AFP, onset of rash in a fever rash, onset of sore throat in a suspected diphtheria, onset of cough in a suspected pertussis. That way. Okay. And minimum this much. If you're kind enough, please give us a vaccination status of that case, if you're kind enough. If you're really broad-minded, give us a travel history and contact history. That is asking for too much, maybe, in a busy OP with busy clinicians. Okay, at least the first 3 part. And support us in sample collection. AFP case, we need 2 stool sample. If the child is admitted in the hospital, the DMO team, they will come with the container, they will hand over the container to you, you can collect the sample here. But many a times, AFP cases may not be admitted. For example, facial palsy, slight limping, it may not get admitted. But then our team will go to the field, they will give the container, they will collect the sample. But the thing will be, you will have to tell the patient, there are some fellows who are going around collecting stool sample as a hobby, give them 2 samples. Unless you tell them, they won't give the sample, because it's your patient. When some stranger or some team goes there asking for a stool sample, okay, this is a conspiracy. They will be selling this stool sample to America and getting dollars. You know how the Malayali psych works. So you please tell them, we give 2 samples to that poor fellow. He comes all the way from Trivandrum for 2 stool sample. Give him sample. We will collect the sample. In AFP, sample collection is easy because of 2 things. One, 80 to 90% of the AFP gets admitted in a hospital at least for 2 or 3 days, because it's a child, it's a paralytic case, it will get admitted at least for observation. So we can sensitize them, we can initiate the sample collection, it will be done. But when it comes to fever rash, 80 to 90% of fever rash is treated as OP. Hardly 10% gets admitted. That's one thing. And 80 to 90% is transient. 2, 3 or 4 days rash, it goes off. So then they are not interested in giving the sample. And the most important thing, stool sample collection easy, but blood sample collecting in the field is not difficult, it's out of question. It will not happen. One, they will not permit. Second, even when they permit, the best of the technician, with one prick, they will not get the vein, especially when everybody is breathing down his neck. You know how when it goes to the field and collecting a sample, it will not happen. Even if it happens in a rare occasion, you take just 1 ml or 1.5 ml of blood, immediate response, you have taken so much of blood from, and the fight starts. So the request will be, whenever you have a fever rash case, one, please do report. Second, support us in sample collection. When you are collecting a sample for anything, even for a routine test, take another 0.5 ml of serum from that patient, keep it in your cold chain, inform us, our team will come, they will collect the sample, they will send it to the lab. Once the report's ready, we will share it with you. So these are the two things we need. One, reporting, and second, sample collection. The last part will be, especially fever rash, because that's what we have in the front of our list or an agenda, because MR elimination is the thing now. So how fever rash can be reported from your busy OPD? Now we have people from pediatrics, from medicine, from gynec, maybe from dermatology, from ID, from various departments. Suppose you have a fever rash comes to your OPD, how it can be reported? I think maybe this is my last slide, no more slides. So after this, maybe 5 or 10 minutes, depending on your time frame, we will have a discussion how it can be reported. That's one thing. Second, how the sample can be collected from this patient, that patient, because it's an OP case, how it can be collected. Third, where it can be made into serum and where it can be kept, because it's a huge medical college. Once a sample is collected, DMO team, the RCH officer is also supposed to come today, but unfortunately he got stuck somewhere else, so he couldn't come. He just called me up. Okay, so they will come, they will collect, they will take it to the lab, they will get the result, they will share the result with you. But for them it will be difficult. It's a huge medical college and with too many securities around. So it will be practically impossible for them to go to the medical ward, pediatric ward, gynec ward, ID ward or any ward searching for the sample, which is not practical. So the request will be, we can have a discussion and we can come out with a plan where it can be kept. Usually in many medical colleges, what's being done from the clinical departments, cases will be reported and the cases will be sent to lab, whichever is your convenient lab, and with that investigation form, because many samples will be tested and it will be charged. Here it's a government program, there's no charge for the patient. So once they go with the form, that instruction has to go from the higher ups saying that if a sample like this goes to the lab, the sample can be collected. And maybe we need the support from the microbiology department. This can be made into a serum. Because the problem with the whole blood is by the time it reaches the lab, it starts hemolyzing. Once it's hemolyzed, they won't even process because IgM is not reliable anymore. So we need the serum sample. So separating the serum and keeping it at one point, because there is one department called infection control department in every medical college, and their hobby is to throw out all the samples which is more than 12 hours or 24 hours kept in any of the wards. But here the problem is a government program, you know how it works. Maybe you are reporting a case on Friday and collecting the sample on Friday, second Saturday, Sunday. Even on a Monday, it's very difficult for some of the workers to work. So second Saturday, Sunday, it's very unlikely, not unlikely they will not. They may not come to collect the sample. So they will come only on Monday to collect the sample, if it's a holiday or something like that. So we need to keep the sample for 24 or 48 hours. So the request will be, there should be a permission for that also, to keep the sample. Maybe we can keep it, in many medical colleges what they do, they keep a box called DMO sample. So there is an ownership for that sample. You can make a box called DMO sample and you can keep it in a fridge or somewhere so that IDP will come, oh, this is a DMO sample, oh, they will leave it. So the sample is safe for us. So that is one thing. So how it can be reported, how the sample can be collected, where the serum can be separated, where the sample can be kept, so that the team can come. That is one part. And second, for the hospital per se, we need a nodal person, so that it is easy for the DMO team, the district team, to interact. Usually, the community medicine team takes the responsibility, because the PET cell or the reporting, this usually happens on the community medicine department. So if the community medicine department can identify a nodal person, and that nodal person will be the nodal person for the entire institution, and the district team can coordinate, or DMO or RCH or DSO can coordinate with that particular nodal person for getting the cases reported, for the sample, and sending back the result. And similarly, a nodal person can be identified, if possible, from each of the department, so that the nodal person of the hospital can interact with that nodal person of the department, so that cases will be reported, and about the sample, it can be in a track, and the result can be shared. So this is the request. So I request each department to come out with their anticipatory bottlenecks or issues that can come up, because every hospital is different. Each hospital have their own issues in getting things reported, because OPs are very busy. OPs are very busy to get reported, and to get these forms filled and sending this one. Especially in fever rush, even without any of those things, in 3 days that patient is going to be all right. But this is a national program, and the big goal is to eliminate 2 major diseases, and without your support it's never going to happen, never going to take off even. So I think we can have a discussion from each of the departments. It will not take much time, but we need to make things into track, and once it's in track, maybe a guideline can go from the top, so that this is how it works for this college. Because last year we did a similar workshop in MOSC Kolancheri, and year before it was ordinary reporting, but last year it's a huge flooding of reporting from MOSC to that level. DMO team started asking, sir, can we request the MOSC to put a break slightly? So we are getting too many samples and too many cases reported. But that way, Ernakulam could find out cases from areas which were totally silent for a long time. And we could pick up so many measles cases, so many unimmunized children, so many activities we could do in the field. So thank you so much.
Thank you, sir, for the very informative session. We are welcome to partner with you and improve the surveillance system and strengthen the surveillance system in Kerala. Now we'll have a discussion on how we can go about it.
So like you said, in the last year, even we have been noting some measles cases. I don't know if it's because we detected one measles case initially, and then we have been more interested in finding out more measles cases. But because personally, I've been here for the last 5.5 years, and in the initial first 4 years, I haven't even seen a single measles case. And in the last 1 year, we just went through the hospital records. There were around 18 IgM positive measles cases. Is it that there has been a resurgence in the number of measles cases, or is it that there has been enhanced surveillance for measles? That's one question. Second is, among those that were identified to be measles positive, we did get a vaccination history, and I'm pretty sure more than 50% were properly vaccinated. Now, if they were vaccinated and still they are getting measles, what really is the role of vaccination? That would be one thing. Second thing would be, is it a new mutation or variant that is causing a resurgence in cases?
Thank you, sir. Two things. One, first part, is it a resurgence of measles? Again, as you said, two things. One, again, as most of you know, for most of the infectious diseases, especially viral things, there is a cyclical thing. Maybe every 3 years or 4 years, there will be a huge spike. Maybe last year was for measles, and all over the globe, you might have read in the newspaper, everywhere, huge number of measles cases were getting reported. That's the first part. Second, especially for India and for Kerala, the surveillance has also gone up. Number of fever rash case report, as you might have seen in that slide, it has gone up, and naturally testing has gone up, so the reports have, just like COVID. When during the COVID peak, every fever, cough or cold was tested, we had lot many COVID cases. Even though we do have COVID, but how many of us are getting tested? No. So the number of cases have come down. Actually, maybe there are cases. The same thing is happening. That is one thing. And second part regarding the vaccination status. Again, many times this is a major question, is a discussion point even at the national level. Like when we get a case, it's been mentioned that 2 doses of MR vaccine, still someone is getting rubella, which is very unlikely. Even with a single dose of rubella, you are expected to get more than 95% immunity. With 2 doses, 99%. 1% always there will be non-responders will be there, or maybe other reasons will be there. But the main thing is, one, when we ask them casually, have you taken all the vaccine? The immediate response is yes. They may not have taken the vaccine. And so what, even during this National Family Health Survey and all that, what we tell all these surveyors will be not to ask such a question. Whether the child has taken all the vaccine, the response will be yes. You ask age-wise, have you taken 9-month vaccine? Have you taken 16 months or 1.5 year vaccine? That way. Again, 1.5 year we are giving multiple vaccines. So the site, whether it was given on the hand, whether it was given on the leg, that way. And ideally, there should be a document. If someone is not, there is a not document, that child, that person is taken as unvaccinated. And by guideline, if it's a child under 5, no document, even if they say that child is vaccinated, we are supposed to give that vaccine which is not documented to that child. That is mainly happening. But 1% there can be non-responders. But genetic variation wise, there are various genetics. For example, the huge number of cases of B8 variant of measles where that's happening in the country. But recently, because of the good surveillance and genetic sequencing, we could identify some B3 variant. It was not happening in the country, but we could get 3 or 4 cases from Kollam district. But all these variants, they respond very nicely to the vaccine antibodies. So the variant or mutation is not an issue, but vaccination per se, that's an issue. Then second, vaccine quality. But again, cold chain, we do have something called as VVM in every vaccine. So if it is exposed to temperature beyond reasonable thing, that changes and we will not use that vaccine anymore. That is one thing. And second, all these vaccines are kept in ILR with cold chain and everything. And it's a reconstituted vaccine. So because of the cold chain issue is very unlikely. So we need to verify whether actually this vaccine had happened or they're just saying that vaccinated. That is one of the things. Thank you, sir.
Good morning, sir. I'm so happy that you've come again and again for the same thing. Now, I just wanted to introduce you to our institution. We are NABH accredited. So we have a system called daily line reporting by our MRD to the district medical office. Now, we have an infectious disease diagnosis being made at the OPD, inpatient and in the lab. So every day we do send, but as you said, under-reporting maybe we are still not doing. So what I was just wondering, we need to report every fever above 100 without any symptoms
no temperature limit. Fever, maculopapular rash, irrespective of the degree of temperature, irrespective of whether the fever comes before or after the rash, and as long as it's a maculopapular rash, and as long as even the slight elevation of temperature, it's to be reported.
This we are maintaining in pediatric OPD at least. And I think I invite you to come with me and I will show you our system. Where are we under-reporting? How to close this gap is something we can do.
Yeah, one of the major issues, ma'am, as you said, the regular reporting goes to the district. And you know how things are. Maybe it goes in a soft copy or even a hard copy. But who is verifying it? No one is verifying it. Maybe at the end of the month when they have to give the final report, that time they only take. Now this IHIP portal has come. Most of the hospitals are doing it in that IHIP portal. Online they are doing it. Even in that also there are 3 forms. One is a P, S and L form. So all the lab confirmed will come in that L list. All the presumptive fever rash, syndromic fever rash will go, presumptive measles will come. But even those cases are not being followed by the district. So my request will be, when you have a fever rash case, when you are reporting to the district, please, if possible, put me also in the loop. Because I don't have much job. My job is to go after these measles, rubella and AFP cases and immunization. But they have too many things to do, including VIP visits and all those things. So I don't have any of those. So if you can keep me in the loop, the minute I see a fever rash, I immediately inform the district, immediately inform the area where that child belongs to. We initiate sample collection, all the public health activity. We will do that. But regular reporting, as you said, it's true. Maybe we are reporting in that official channel, but nobody is looking at that report.
Feedback, can we find some form of a feedback through a digital platform?
Like?
Maybe, see, as you said, we have reported
No,
the sample
once you report the case and once a result is ready, immediately inform you in both the ways. One, whoever has reported in that WhatsApp number, I send the report. That is unofficially. Officially from the DM office, that report copy will come to the institution. Both the ways it will come. Yes, ma'am. Thank you. Thank you. So what we need to know is the bottleneck from the busy departments, maybe medicine, dermatology, ID, gynec. What's the problem in, or what can be the anticipated issues in, anticipated issues in reporting from a busy OP, especially fever rash. Mostly it will be, as you know, sir, it will be OP cases.
Sir, what we will try to do is, the problem is going to be in the OPD. IP won't be an issue. We will be able to report the fever rashes, and ED will also be an issue. So a few things which we'll suggest is, one is we'll have to make a service order from the lab. I'm sure Abel will help us, wherein a service order has to be created for the sample to be kept, an extra sample, and so that the lab also knows the moment this particular order comes up, whoever is there takes a serum and saves it. Maximum 4 days or 7 days, sir. How many days would you expect a sample to be kept, to be collected fever for rash?
Usually the next day the team will come and collect. Usually, but
upper limit?
Maybe 2 days. Because usually second Saturday, Sunday, if it's the Onam thing, maybe 3 days or 4 days.
So we'll give 4 days.
Yeah,
we'll give 4 days
yeah,
as upper
that'll
limit.
be excellent.
That'll be one.
Yeah.
Second part is going to be, we just formed a group on WhatsApp for our OPD and our junior doctors, and we will have to empower our nurses who stay in the OPD, who takes the vitals, and start telling them to ask the same question, do you have fever with rash? So they also can report with the basic details. That's something which we just started. We just made a WhatsApp group. We've added you also there, so that the reporting part will go up. But definitely collecting a sample in an OPD will not be possible. That will become a difficult part. Collecting serum in an OPD, advising them also when a child is fine with a fever with rash will become tough. IP won't be a problem. ED also might not be an issue if there's any other investigation being done, we can, but mostly fever with rashes day 2, day 3, unlikely for the other cases which doesn't fit into measles, investigations will be done. That will be the bottleneck.
Yes, as you said, that is the bottleneck, and the issue is with the fever rash, 90% it's OPD cases. 90% is OPD. So unless we get the sample from those cases, there will be a huge lacuna in that surveillance. And by algorithm, if you report a case and there is no sample, especially serum sample, it becomes measles. So unnecessarily our measles burden will go up. Clinical measles will go up. If it's a small baby, as you said, maybe unless you are taking it for some other purpose, we may skip that. But if it's a slightly older child or
very
adult,
difficult to convince the patient who comes to the OPD to do a blood test when they feel the child is absolutely fine, especially when we are saying this is part of the survey, because most of the times we won't investigate at least on day 2 or day 3 or day 5 in an active child, which is classically in a case with viral
symptoms. Yeah.
So that is where that is going to be the bottleneck. Yeah. But at least we can assure you our reporting numbers will go up, and we'll see how it works from there. Sir.
No, sir. At least to start with, at least one couple of cases we'll try to, maybe we'll try to extend, because without the sample, this is one of the issues. Unnecessarily, it may not even be measles, but by algorithm it becomes measles. That is one of the issues. But try to support us with the sample also. Thank you, sir. Thank you. Even in an older child or even an adult, to collect the sample from OPD, how it can be done? with the form, if they can go to whichever the lab, like if it's a hospital lab or micro lab, wherever, I don't know, where they have to go. And we should sensitize the technician there also that this sample is for DMO office and should be kept up. It should go to micro for serum separation and to be kept for as 2 or 3 days.
So suppose we are getting a child like 11-year-old and he's found to be measles IgM positive. Though his immunization status has been complete till 5 years of age and he has already received 2 doses of measles and rubella containing vaccine. Is there any role for a revaccination at that particular point, or and if so, when?
As you know, if it's a confirmed case of measles, child gets protection for usually 99.9% protection for life. Please, ma'am. But if it's a child under 5 years of age, if the child is under 5 years of age, irrespective of IgM positivity or negativity or whatever, that child will receive the routine doses of MR again because of 2 things. One, if IgM positive is a confirmed measles, but again we are giving MR vaccine which contains rubella also, so we need to give. If the child is beyond 5 years, even if it's a confirmed measles or not, child will not get vaccination, because as per Government of India guideline, from the national immunization point of view or from the government setup, MR vaccine can be given only up to 5 years of age. 5 years of age. So this is the way. If it's under 5, if the child is due for any of the doses, it will get no additional dose of vaccine. No additional dose of vaccine. That happens only for AFP cases. We get additional OPV, not for any of the other things.
Immunization status of those reported case of measles.
Yeah, we will have, because I just want to make it a very, maybe I will share it with you. We have that. We analyze every case for this immunization status also. But again, in that, the major issue is, even under 10 years of age, in many of the case sheets or many of the forms, it's written as unknown. It comes out as unknown. Why it happens? Because a child comes to medical college. That time they may not have, they won't be having that immunization card. So immunization, it will be marked as unknown. Actually, it is to be corrected or rectified from the field. Now that instruction has gone from the top to all the field workers. If you have a case from your area, please update that sheet with the immunization details. In the last year analysis, this is one of the biggest things. More than 40 to 50%, even children less than 10 years, unknown. It never happens in Kerala, either yes or no. It will never come as unknown. If it's a 20-year-old, 40-year-old, yes, unknown is acceptable, but not for a child under 10. But even 40% comes as unknown because of the documentation issue. This year, that will get corrected, rectified.
So, is it to send the sample for AFP, stool samples, you said it has to go to Bangalore. Is there any transport medium advised?
No, ma'am, only cold chain, 2 to 8 degree. When they come to collect the sample, that for any of those samples, they bring that container with a stool carrier or an old vaccine carrier labeled as not to be used for vaccine delivery. And with the ice pack, they will bring it. They collect the sample. Just before couriering it, again, they change the ice pack, and within 24-36 hours, it will reach Bangalore. So, no transport medium.
What about samples like for diphtheria, you said?
For diphtheria and diphtheria pertussis and the swab of measles rubella, we need a transport medium. Will you
provide the transport medium?
For the measles or fever rash, it's a COVID transport medium or the viral transport medium, I think, which is available. But the other two, once you report a case of suspect diphtheria pertussis on the district, they will bring you that transport medium and the swab.
So both. It's our duty to report only.
Yes, ma'am. Why it is not being supplied? Because the number of suspected diphtheria pertussis case report is minimal, and the shelf life of these both RL and AMS is maybe 6 months or 8 months. So that's why we'll be wasting those. That's why we are not. But if you get many cases, always we can provide you with transport medium and swab. No issues. But otherwise, once you inform from the district, they will bring in the swab and the medium.
if there are no more questions, we'll wind up the session. Once again, thank you, sir, for the very informative session. We promise that we will try our level best to strengthen the surveillance and help to prevent these diseases. Thank you, sir.
Thank you, sir. Thank you all the senior faculty here and all the PGs or students who are. Thank you so much. Thank you.
Thank you, sir. Have a good day. See you next week for the quiz program.